Hello, everyone. Welcome from me as well. My name is Katerina Panagaki. I am the lead for Health Equity Mainstreaming with ARC Northwest Coast. And I'm very pleased to have with us Dr. John Ford, who's the director of the Health Equity Evidence Centre. I met John at the last NHS Confed Expo, where he started, explaining the process they've developed using machine learning to synthesize evidence into living maps, what they call living maps, and produce that way evidence briefs on what works to help with implementation, but particularly with targeting health inequalities, which is a topic very dear to our heart and the ARC Northwest Coast. And I certainly wanted to learn more. And judging by the over 150 people who have expressed an interest in this webinar, it seems I'm not the only one. I think how to embed an equity lens when synthesizing evidence is something lots of us struggle at times, but are very interested in how to do. So welcome, everyone. Thank you for joining us. Thank you, John, for joining us. What we'll do today is we'll hear John speak and explain their model and process of how they go about this for about half an hour, and then there'll be plenty of time for questions. Please use the Q&A to type them in, and I will then do my best to moderate and feed them to John at the end of his presentation so he can give you all his answers. If you're active on social media, we're using #ImplementEquity today. And just to say as well, the session is being recorded and we'll do our best to release as soon as possible after this on the ARC Northwest Coast YouTube channel so you can watch again or share with others. And without further ado, I'll hand over to John.
Great, many thanks, Katerina. So I'm an academic public health doctor. So I work as a senior clinical lecturer in health equity based in Queen Mary University, that's in East London. And I also work as a consultant in public health with NHS England and the national team for one day a week. About a year ago, we launched something called the Health Equity Evidence Centre, which you may have come across. And that arose really after, two parallel, I guess, experiences. One is, having spent the past 10 years or so doing health inequalities research, really coming to a sense that we had lots and lots of research describing the problems of health inequalities, but very little evidence which sought to build the base around what works to address health inequalities, and the need for policymakers and practitioners to have practical, tangible, evidence-informed approaches to address inequalities. And then secondly, I started my research career off working with NICE about 15 years ago, and spending months and years screening titles and abstracts, doing reviews of both clinical and cost effectiveness of new drugs, and having done a number of reviews over the past 10-15 years, coming to a realization that actually the evidence base is just changing dramatically. There's so much being published now, and a kind of frustration that reviews take such a long time, yet they go out of date so quickly. There's got to be a better way of navigating the literature, and so that's where we came up with this idea of the Health Equity Evidence Centre. So what I'm going to do today is I'm just going to explain a bit about how we're using machine learning and what we do. I'm going to start at the end of my presentation by just giving you a quick demonstration of what I mean by living evidence maps. So I'll talk about living evidence maps at various points throughout my presentation, but I just want to give you a quick demonstration of what it means so that as we go through, you know what I'm talking about. So this is our website. Within our living evidence maps, this is an example of one of our living evidence maps. So they're all publicly available. And essentially, this one looks at primary care interventions in disadvantaged groups. Each circle represents either a group of primary studies, umbrella reviews, or systematic reviews. And essentially, this gives you a map of different disadvantaged groups and different interventions. We've got about 11 of these different maps, but for example, if someone's interested in community or link workers for different minority ethnic groups, they can click on a whole body of research studies which look at that topic. They all focus on inequalities and what works. and they're maintained by our machine learning software. So without further ado, I'm going to just break down how we get to these living evidence maps and how we're using them to hopefully navigate the literature. So let me just organize my screens. In terms of where we started from, so about it's probably about 2 years now. We were successful in getting some seed funding from NHS England, East of England team, and so that was about 300k to do three main things. One, to create these living evidence maps, and the seed funding came from the primary care team. So the living evidence maps at the minute primarily focus on primary care. So they wanted both us to create living evidence maps and produce some useful guidance for practitioners, policymakers, to do some data analysis, which I won't talk about today, but you can have a look on our website if you want to see the kind of data stuff we've done. And then to pull it all together in accessible online resourcing hub. And that's the Health Equity Evidence Centre website. So over the next 20-25 minutes, I kind of want to do three main things. One, just to go through why we need to use software developed through machine learning to help us navigate the evidence. Secondly, kind of break down how we're using it and what it actually does. It's not rocket science. And then potentially then I'll just give you a quick live demonstration of what it looks like and how we're using it. So for any of you who've done systematic reviews, hopefully this is fairly familiar with you. It's a kind of process of undertaking a review, starting with the research question to search strategies, screening, extracting, synthesizing, writing, and then finally submitting. Previous research has estimated this can take up to an average of 16 months from designing the research question to finally publishing them. So that takes a fairly long time. For those of you who've had much interaction with NHS England, ICBs, DHSC, 16 months to do a literature review is just too long for them. They usually want the answer within weeks, occasionally a few months. So they take a long time to do. Not only do they take a long time, they take a lot of researcher time as well. So again, for those of you who've spent hours, days, weeks, months screening titles and abstracts, you'll know that it takes a lot of time. Here's just an example. So this is a review which looked at the risk of dementia, cognitive or chronic cognitive impairment after mild traumatic brain injury. And these researchers team screened through 78,000 articles and came up with 300 articles which are eligible, but only 100 of them met the methodological eligibility criteria, of which 8 of them were finally included. And so you can hopefully imagine how much work this took that team of researchers to look through 78,000 articles to reach the 8 they needed to include. And undoubtedly not every review goes through 78,000, but you know, even if you're looking through 5, 6, 7, 8,000 titles and abstracts, it still takes a considerable volume of time. So not only do they take a long time, take a lot of effort, they also go out of date fairly quickly. Again, any of you kind of published a review recently, you'll know that actually from the point you finalize your results and submit the manuscript to when it actually hits publication can take months and months. Again, these researchers have previously looked at the date at which a search was undertaken and the date at which a review was finally published, with an average of anything between 8 and 22 months. So some reviews, even on the day of publication, are already months and months out of date. Again, not ideal for those of us who want to be trying to influence policy and practice. And it's made even more complicated just because of the ballooning number of publications which are being published every year. So this is just a graph showing the number of publications with primary care and inequalities in the title or abstract. And you can see that over the past 20 years, or past 10 years, there's been this 300% increase in the number of publications. And this is similar in most other disciplines. There's just been this absolute enormous increase in the number of academic publications. And so certainly when I was working with NICE back in about 2010, we could do a systematic review and we could identify every single study relevant to that topic, which had been published. Nowadays, these kind of reviews where you identify every single study related to a topic just becomes increasingly unmanageable, just because of the sheer volume of studies. And actually, for policy and practice, policymakers and practitioners are less interested in having a review of every single study ever published under the sun. They're more interested in finding the most relevant and robust studies, which are good enough to inform policy and practice. So all in all, it become this model, the traditional model of systematic review, just feels like it's becoming increasingly unsustainable, both in terms of the number of publications which are being published. We're also getting better at undertaking searches and finding more, with more and more being shared. There's also this issue that actually the questions that we tend to ask now tend to be a bit more complicated than they were 15, 20 years ago. Again, there's fewer and fewer reviews looking at, does drug X work for condition Y, and much more around, well, you models of care within complex health systems. So actually the types of reviews we're trying to do are getting more complex as well. So with all that in mind, what are the opportunities within machine learning to help us try and navigate all this published literature? So there's a few different opportunities, and you may have seen some of these, you may have used them yourself. So the kind of four main areas are: one, identifying studies, relevant studies, and that's the part I'm going to mainly talk about. There's also now software programs that can help with data extraction. So you may have already put in a journal PDF into ChatGPT and asked it to extract some data for you. That can be done on a much larger scale in terms of bulk extraction. So that's already happening. There's also software packages that will now map research activity. So both in terms of citation tracking, but also in terms of related authors and related topics. So software like Research Rabbit or Litmaps are already out there, which can be used. And there's also now software which will write briefs for you. There's things like ChatGPT, which again you may have played around with, but there's also more academic AI generative software like Cite, which also includes references. Like our experience has been that certainly the writing of the briefs and the extraction of information isn't good enough yet. We've just got some funding from the Health Foundation to do a more in-depth study looking at it. Certainly the mapping of research activity we use a bit, so in terms of Litmaps and Research Rabbit, but that's similar to the kind of citation tracking that we would have done previously, looking through hand searching reference lists. But today I'm just going to focus on this identification of relevant articles, about how we're using them to create these living evidence maps. And I want to just kind of break down this process because it's not particularly complicated once you understand it. So essentially there's these 6 main steps that we go through. One is we start off with a set of training material, and we used our Equalize study plus a few other health equity reviews we had, and we used those previous reviews to train an algorithm. We then employ this algorithm on a data set called OpenAlex, which is similar to Google Scholar. It's now got about 240 million records in it. It's mainly journal articles, but also includes some PhDs and master's theses. So we then use the algorithm on OpenAlex, and then we do kind of belt and braces of doing some citation tracking and adding in related articles as well to the algorithm. I'll tell you a little bit about that. That essentially ranks those 240 million records from most similar to least similar, and it means that we just look at the top of the pile, and we still manually look through to those, but actually because they're the top of the pile, most of them are relevant, and then we label them. They appear in our evidence maps. Because it's kind of driven by machine learning, it means that actually we can recalibrate the algorithm every month. It takes us maybe 2 or 3 days to update the living evidence maps every month. So it means that the evidence maps are living in the sense that they're being updated every month. We as a team then produce evidence briefs, so we turn those living evidence maps into accessible summaries for the NHS, but they're also openly available for anyone to use. So that's an overview of the process. This is our equalized study, which is a realist review looking at what works to reduce inequalities in general practice. I won't go through the results of it, but just to say, we went through quite a in-depth process to identify relevant articles. So we started off with systematic reviews. We screened through about 8,000 titles and abstracts. We came up with a list of 251 reviews, and we unzipped those 251 reviews, and we came up finally with a list of 325 primary studies which were relevant. So that meant we essentially had two sets of training material, one with about 7,750 articles which we had excluded, and so we had them labeled as excluded, 250 which were labeled as included. Those were reviews, and then we had another set of training material of which about, I don't know, just over 6,000 were labeled as primary studies labeled as excluded, and 325 labeled as included. So we used that training material as well as a few other reviews which we included, and then to train an algorithm. To train an algorithm, again, it's not rocket science. It tends to use this bag of words approach. So here's an example of trying to identify randomized controlled trials. So essentially, in every column is a different word that appears in one of the titles or abstracts of both the included and excluded. So all that 8,000 articles. And essentially, at the very end, you can see the relevant column, and so that's whether it's included or excluded. So the ones are includes, the zeros are excludes. And essentially, if you can imagine this table not just going on for 6 columns, but tens of thousands of columns with every word, plus also common phrases. And instead of just 3 articles, we've got 8,000 articles. Actually, when we add in all our other reviews, it goes up to tens of thousands of articles. And essentially, for every word which kind of commonly appears in included articles, we work at a coefficient. So, for example, in this example, article 1 has the word randomized in it, and it's included. Number 2 also is included study, but it also has randomized in it, and so the coefficient's quite high. Whereas article 3 doesn't have randomized or in it, but it's got ranitidine and systematic, which don't appear in the included articles, so it's got a much lower coefficient. So essentially, using this bag of words approach, we calculate the coefficients. We can do that using standard regression techniques or more sophisticated neural network techniques as well. But this is the kind of, I guess, the basis of it, of training algorithms to work with these coefficients. These are the coefficients that are then applied to OpenAlex, that 240 million articles, which then allow us to pull out, or allows the algorithm then to rank the articles with the strongest coefficients words to the very top of the pile. It's something that we could have done 30, 40 years ago, but the big difference now is we've got the computing power to do this on a huge scale with tens of thousands of words and phrases and tens of thousands of articles, and then employ it on a data set with millions of journal articles. So that's hopefully kind of get a bit of an understanding of how we train an algorithm. Um, so this is just giving an overview of that. So we've got the training materials. We then use this bag of words approach. The coefficients are then learned from that training set, and they're applied onto our OpenAlex, which gives a probability of each article being similar to our training set, and then they're ranked from most relevant to least relevant, which means that we as researchers just always look at the very top of the pile, the most relevant. So it's kind of like this process. So if you imagine that the top line is a traditional review, and you've done a search, you've got 5,000 articles, you're looking through every single title and abstract to see which ones are relevant. You'd expect them just to occur randomly throughout that 5,000. So you begin however many, one or two per 100 or per 1,000, and that rate would continue to be fairly steady. Whereas what we're doing is we're priority screening, so we're essentially trying to pull the very best articles to the very top. In reality, it looks a bit more like this, where actually we can then go on for millions and millions of articles. We're always going to miss a few. The purpose of this is not that we will have evidence maps which contain absolutely every study, but the idea is that we're able to identify the most relevant and robust ones and enough of an evidence base to make decisions. Again, this is a slightly different way of explaining that. So the grey line is what you'd expect if you're just doing a traditional systematic review. So you'd expect a similar number of articles to be included as you go along. Whereas what we're aiming for is something more like the green or the yellow line, where actually we can just screen the first 10, 20%, and actually within screening the first 10 or 20%, we've identified most of the relevant articles. So that's the basis of the kind of machine learning training algorithm to priority screen and how we've then used it. To add kind of belt and braces to that, we use citation tracking and related articles. So citation tracking is something which you may be familiar with. So for every journal article, within that journal article, it will include a list of citations, so studies it references in its bibliography. You can then look since that article was published to which other articles have cited that article. That's called citation tracking. It's been done for several years now. And actually we can quite easily do that within OpenAlex. OpenAlex also has its own machine learning driven related articles. So you may have been, if you're on PubMed or if you're on any kind of Elsevier website or other publisher website, you may have seen that it comes up with suggested articles, related articles, which is based on the topic, the author, citations. Then actually OpenAlex has a similar function. So we add those into the priority screening as well as a way of ensuring that we're not missing key studies. We then take those living evidence maps. So once we've priority screened, we've labeled them, they appear in our maps. Those maps are then openly available, so anyone around the world can go and have a play around with the living evidence maps. We then take different topics from the NHS. So they maybe suggest, a topic on case finding for hypertension, and we essentially look within the evidence maps to pull out the evidence, and we do a kind of quality assessment using kind of Medline Embase to make sure we're not missing stuff. We synthesize and write it up. And it means that because we're not spending lots of time screening titles and abstracts, actually we can turn these around in about 4 to 6 weeks, which includes a researcher pulling some of the studies, synthesizing it, and then having some expert input as well. One thing that we've tried to promote within our evidence centre is this idea of transferable evidence. So we know within health inequalities that there are some common themes which keep recurring around what works to address inequalities. So we know something like culturally adapting services comes up again and again and again. We also know things like community engagement, co-design comes up again. We know that things like designing services with which require low patient agency, so low patient effort to benefit. Again, something comes up again and again. Or allocating resources proportionate to need. So there's some of these principles which come up again and again within the evidence base. Sometimes the ICB suggests topics, or NHS ask us to have a look at evidence, and there's just not much evidence out there. So, for example, we're asked to look at something like inequality, how to address inequalities in the interface between primary and secondary care. So when primarily GPs refer to specialists in hospitals, we know there's inequalities which occur in terms of people either not being referred or dropping out of the system and struggling to attend for whatever reason. How do we reduce inequalities? There's not that much evidence out there examining how to close a gap. There is evidence describing the problem, but not that much describing what to do about it. But we've got some of these guiding principles, which we know have been evidence-based in lots of other areas, services, where we can then logically apply to that area, so we can give the policymakers, practitioners some evidence-informed principles. Clearly, we need to communicate the uncertainty of those recommendations and where we're taking evidence from and where the transferable evidence is, and we communicate that using grade. But we're trying to use this idea of transferable evidence. What we don't want to do is produce evidence summaries which say, there's not enough research, more research is needed. When we know that there's some evidence-informed guiding principles which we could logically apply and communicate the where that evidence has come from. We're certainly not trying to do systematic reviews, and I don't think these machine learning algorithms will be able to do the systematic reviews to the depth which, for example, the Cochrane standard would do, where they are trying to identify every single study published. Our evidence briefs are then published online, and we've got a pipeline to academic publications, so we're planning to publish them in a public health journal as well. I'm kind of going to be publishing them as a mini-series. To date, we've done about 19 of these evidence briefs, so you can go and have a look through them. Here are some of the topics. I won't go through them in detail, but they cover all different subjects, from screening to case management or case finding and digital health literacy, etc., etc. These topics tend to come from the NHS, so they're not ones that we necessarily choose, and that kind of reflects some of the messy topics which they ask us to have a look at. I'll give you a quick demonstration of what I mean before I finish, just to say you can stay up to date with what we do. We've got a LinkedIn, it's probably the best way. We've also got a mailing list, so if you go online, you can sign up to our kind of monthly mailing list, which just distributes which evidence briefs or data sets we've been publishing. So just as a final quick demonstration, I'll just show you how these all work in practice. So let me just share my screen again. So this is our website. Within our website, these are all the evidence maps we've got. So they click through, they take you to the software that we use, which is EpiReviewer. So these are maps which are produced by EpiReviewer software that's produced by UCL, and essentially there's a whole range of different evidence maps which you can view. We can cut up the data and the journal articles in lots of different ways. So these just reflect the ways in which we've decided to cut it up. Clearly behind this, we can also do searches. And we then turn the evidence maps into these evidence briefs. And essentially the evidence briefs then go through the evidence. So, for example, includes a kind of sort of abstract or summary of the evidence, current challenges, and then sets out the evidence in hopefully a reasonably accessible way. And then finally ends with some recommendations with our grade certainty and who they're targeted at. So that's where our evidence briefs look like. So I'll stop there. I'm happy to discuss any questions.
Thank you, Jen. Thank you for the very detailed presentation. It was great to hear a bit more about the evidence maps than I had a chance to last we spoke and how they work. For everyone, please feel free to add your questions in the Q&A section and I'll try and read them out. We do have quite some time for questions. So I'll start. I think there's some questions because people are starting to see how they might be able to use this. So there's questions in, how it was done, but also where would it apply? So Fiona was asking first, how many documents did you use for your training material?
Yeah, so we probably end up using about 20,000 documents. And actually, once you get over 2,000 or 3,000, that's really enough. It doesn't take tons of training material. I think that one of the issues or the challenges we faced was actually as we went along, we slightly tweaked the inclusion criteria. So initially, we just started looking at reviews, and then we added in primary studies. And actually, adding in primary studies meant that the algorithm had to get up to speed with that, and so that created some confusion. So we had to keep retraining it. But actually, it doesn't take tons of training material. I think I would also say, actually, it took us probably about a year to set it up in terms of training it, testing it. We did quite a lot of quality assurance in terms of checking the results, making sure that we were happy they contained a reasonable body of literature. And so actually it works really well for a topic like health inequalities and what works. Actually, if I was to just do a review of an individual topic it's probably not worth going through all the hassle of trying to set up a machine learning living evidence map for an individual review, which is just kind of a start and finish review rather than something you're going to on to maintain. All those other machine learning software which can help with those types of reviews.
And I guess following from that, Fiona wanted to clarify if it was just RCTs that were included, but Kenneth was also asking if this is a process that could be used with qualitative data or studies, or is it just more so with quantitative that we're talking about?
Yeah, so it could be used for anything. We include both quantitative and qualitative. We do include some RCTs, and to be honest, there's not tons of RCTs out there. So just to give you an idea, we've got about 800 articles within our living evidence maps somewhere, and the vast majority of them will be some kind of evaluation or and not a RCT and a kind of a non-RCT evaluation type study. The machine learning process is actually pretty good for these fuzzy topics. So, for example, qualitative methods, or if there were non-traditional evaluation methods. And that's because if you've got a group of studies which are the ones you're looking for, you can train the algorithm. Actually, if I was doing a review just of randomized control trials, that existing search terms within Medline and Embase are actually pretty good. So again, the machine learning software isn't really operating at its best when using quite strict criteria of randomized control trial or not, or drug A or not drug A. Actually, it's much better these fuzzier topics where it needs a bit more of a training.
And you mentioned, John, that you have a whole team that works on producing policy briefs and practice briefs out of this. Melissa is asking, are local authorities or HDRCs, that's health determinant research collaborations, involved in this process?
So they have been to an extent. So our initial funding came from the primary care team within NHS England, East of England team. And so when we developed the maps, it was very much focused in primary care. Over the past 6 months or so, we were commissioned by DHSC to do some more community engagement type briefs. And so we have included more data relevant to local authorities and HDRCs. We're really keen to, we've designed it in such a way that we would like to, at some point, do more local authority public health type evidence reviews, and we've got we've got some plans to do that. But we'd be really interested in speaking to others who are interested in that space, because it's something that certainly could be done.
And I guess people want to take it away and run with it. So the question is, if we've got an impeding systematic review, how can we use this?
So very practically, if you've got a systematic review, you can go and have a look at our evidence maps, and it will hopefully give you a body of literature which you could either use as your initial background reading. You could use it to kind of quality assure what you're doing, or to find other studies. So that's a kind of obvious way of doing it. Like if you're starting a new systematic review and you're interested in using machine learning methods, actually, developing a whole living evidence map is probably not going to be possible. But actually, there's machine learning software out there. So you may have come across LitMaps or Research Rabbit, which does some of the citation tracking, which I think is worth having a look at. Both in terms of doing some of your initial study identification, but also doing some quality assurance and checking at the end.
And thinking about the process where you said where the questions come up, that they're very tied to a specific context, what's happening on the ground, that's how the questions get fed to you, and you're asked to do those reviews. So Kate is asking, to what extent does this process take into consideration that context of how the evidence is then going to be applied, or is that something that people have to do after they read your briefs themselves?
So I guess the perspective we've taken is that there's some things which make sense to do on a local level, and some things which make sense to the regional, national level. And certainly this evidence synthesis and gathering makes sense to do at the regional, national level. And so what we try and do is we try and produce the evidence and synthesize it in such a way that local decision makers, NHS bodies, GP practices can take it and apply them to their own situations. And I think one of our reflections is that the health inequalities evidence is different to some of the traditional biomedical RCT type evidence. There's not kind of silver bullets which you can just worked in a randomized controlled trial. You take it and implement it and policy and practice, and suddenly, hey presto, health inequalities are reduced. Because health inequalities tend to be very contextually relevant to individual services, communities, neighborhoods, then actually I think it's much more around identifying these guiding principles which then can be applied. And so what we quite often do is take those guiding principles and then give some case studies about what this means in practice. So if it's something like culturally adapting services, actually, what are some of the examples of how local areas and systems have done that? So that's how we try and get that balance between not being so tied to local context as only relevant to that individual area, and yet not being so high level that actually local NHS organisations struggle to think about how they're actually going to implement some of these evidence-informed recommendations.
And can I expand that question myself here to ask you a bit about the process of how those questions get fed into you, and whether there's, I don't know, a form that helps them be specific enough for what you need, or not too specific, or how does it meet those criteria? How do you manage that process?
So we've over the past year we've taken them from ICBs in NHS England. As some of you may have had experience, NHS England and ICBs, my experience is they tend to come up with questions which they haven't quite thought through fully. It tends to be an area or topic where they're interested in. They think, okay, we need to do more around community engagement. So there is quite often a discussion around, well, actually, what parts of community engagement, what are the outcomes you're trying to achieve? Actually, we do a quick review of what's out there and think actually there's lots of different components, different ways in which we could take this. So there is a bit of to and forth in terms of identifying more what they're wanting, and part of that's also about managing expectations, and that again, my experience is that some quite often policymakers and practitioners think that if we do a review of the evidence, it's going to tell us the answer of what to do, and we'll just be able to take it off the shelf and implement it. When it's rarely like that. It's usually a case of having to review the evidence, think about what the evidence-based recommendations or principles are, and then think about what that means for a specific context.
Yeah, I can see that happening. So Katerina is saying she's very new to machine learning. So for the bag of words model, how do you define the words, or does the tool identify the words itself from the training set?
So within the machine learning tool does it all. So it essentially looks through every single word and phrase within the title and abstracts. So we don't choose that at all. And essentially, because of the computing power that we have nowadays, actually that can be done relatively rapidly. So we don't have any hand in saying actually, we want you to look at inequalities and equity, but actually based on our training materials, hopefully the words related to inequalities, what works, and disadvantaged groups does come up, and actually we know that from the results of our training material, that actually as we've gone over the year, that the precision of the algorithms getting better and better.
I see what you mean, but I'm also thinking, there's the issue of terms like inequalities, equity being umbrella terms and meaning different things. There's also the issue of when people use proxies to measure one thing but mean another. How does that work out with your algorithm and keyword training?
Yeah, so again, this is where the machine learning becomes really effective, in the sense that actually whether we as long as our training material is good enough, and actually as long as we've got a mixture of equity, inequalities, inequities, disparities, we've captured that body of literature, then actually the algorithm will be able to learn and identify those terms and those studies with those terms in it. And the problem comes that if we just focused on, for example, UK literature and the UK terminology relating to inequalities, we may be biasing the algorithm not to pick up North American literature, for example.
Right. And then we've got a question from Fiona who says, is there a way to see how do you show the studification overlap between your systematic reviews and primary studies?
Yeah, good question. So at the minute, not. And interestingly, actually, if you have a look at the maps, there's quite often there's either a similar number of primary studies as systematic reviews, or there's some examples where there's more systematic reviews than primary studies, which has been reported elsewhere. This kind of odd situation we're in, where there's quite often more reviews than there are primary studies in some topics. And part of that, well, that's to do with a whole number of reasons. But in terms of the overlap, at the minute there's not. You can see which reviews have included which primary studies. It's really interesting point. It's something we've toyed with in the past. I'm sure there is some way of linking them, because there's other software packages that do that. But at the minute, we don't do that within our evidence maps.
And you're based in London. Does that mean you're focused on supporting requests that are coming from London Trust ICBs, or do you have like a regional constraint, or can we all reach out to you?
Yeah, please do reach out. We set it up as a national collaboration, and so we do work quite closely with Sheffield and Newcastle, Cambridge. We'd love to work more with the Northwest. So if you're interested in collaborating on some of the resources, or collaborating on some of the evidence reviews that we do, please do get in touch. Really keen to work together. And I guess our mission is really about how do we build evidence base around what works, and we're conscious that actually we're just one small part of that. And actually it takes us all to kind of work in partnership with each other to try and achieve that.
And Andy is saying, giving the evidence you described around health equity being fuzzy terms, what does that mean for the certainty/uncertainty of the findings?
So it means that actually that the evidence maps are never going to be 100%. We've because it's this fuzzy topic, and because health inequalities covers lots of different domains, both in terms of social sciences, some trials, some epidemiology, etc. It means that actually the body of literature we have within our evidence maps are never going to be entirely complete. So it means that we are going to miss some stuff. I suspect that we don't have tons of examples from low and middle income countries which could be applicable. Again, because, for example, when our initial reviews excluded most of that stuff. So it means that actually the fuzziness reflects the fuzziness of our training material. And it means that there is quite a lot of uncertainty. I guess we're more comfortable with that because of the way we've been handling evidence and acknowledging that within health equity evidence, actually there's always going to be a big degree of uncertainty because of the unique contextual factors such as individual communities, services, interactions between communities and services, historical neighborhood factors, all that kind of stuff, which undoubtedly always brings in some uncertainty. And so we're always hopefully fairly careful to try and both communicate the uncertainty and frame these as evidence-informed recommendations. We don't try and make grand promises around the certainty of impact of the interventions we recommend.
And so there's fuzziness about the terms. Is there a mix of the type of studies you look at? So Carly's asking, are you just focusing on journal articles, or is the algorithm also looking for reports and grey literature and other sorts of things?
Yeah, really good question. So at the minute it's just academic outputs. So it's primarily journal articles. There may be one or two master's theses, PhD theses, that kind of stuff in there. And it does include all different types of journal articles. So include, quantitative, qualitative case reports, any type of journal article. The whole area of grey literature is something we've discussed quite a lot. So at the minute we don't have any grey literature. When we produce our evidence briefs, we do have a search for grey literature. So the grey literature appears in our evidence briefs, but that doesn't come from our evidence maps. I think there's a huge gap in terms of how we handle grey literature. You may remember some time ago there was resources like Open Grey, which were repositories for grey literature. At the minute, it doesn't feel like there's any good way to navigate the grey literature. I think there's some fundamental concerns around the power imbalances around different types of evidence, especially in relation to health inequalities. For the communities and individuals that we serve through our health inequalities research, for many of them, what evidence and knowledge is very different to what we understand evidence and knowledge to be. And how do we respectfully acknowledge the evidence and data which is produced from voluntary community sector partners, and how do we incorporate that into how we our evidence synthesis, especially to national policymakers. I think there's a huge area which we haven't gone top of, and which we really need to, and how do we do that with academic rigor and robustness as well.
So Ruben has a question, I think it's very close to one I had. So he says, how do you assess the accuracy, precision of the training algorithm, and how do you quantify the level of uncertainty in the output? I think you mentioned that you use a grading of your outcome. So maybe you can tell us a bit more what that looks like.
Yeah. So in terms of the precision of the training algorithm, so before we published anything, we went through quite an extensive quality assurance process, which was essentially us using that. We produced some initial evidence maps, and we then independently as researchers did Medline-based reviews, found articles which were being missed, then did some kind of look back exercise in terms of why are we missing these articles, and then fed try to add those into the algorithm to make sure the algorithm was working. So we went through quite a robust process of doing that. And even when we produce evidence briefs, we still do a very quick and dirty Medline M-based search and grey literature search to kind of top it up. In terms of quantifying, we don't have a measure of quantifying. What we do is we track how many included articles we're getting every month. So, when we started off, we're including lots at the top of the pile, and actually over time it comes down. So what we do is we track the number of included articles month by month, and actually we see quite a nice steady reduction. So that's probably the best way we quantify the outputs. And then in terms of the evidence synthesis, we use grade to try and communicate the uncertainty of the evidence backing up the recommendations. We have to be slightly careful with grade. Like some of the feedback we've had from practitioners and policymakers is if we give our recommendation is grade a very low, which is because there's not tons of evidence on that topic, that can be interpreted as we shouldn't do it because there's no evidence. That's not necessarily what we're saying. So we have to caveat grade a bit by saying actually it doesn't mean it's not the sensible, logical thing to do. It just means that there's not research evidence which we think's robust enough to back it up.
And the policy briefs that you produce, I know we didn't go much into that now, but can you talk a bit about how they get disseminated or how you get them shared besides the teams, I guess, that ask you for that evidence?
Yeah. So to date, over the past 12 months, most of them come from either ICBs or NHS England DHSC, so they kind of naturally go back to them, and then we do the kind of social media stuff, go mailing list. I guess we're at the stage where we've now got a library of these evidence briefs. We're kind of over time we'll hopefully build that library to be bigger. We then have a mailing list which goes out every month, and I guess we're in the process of then thinking about how do we map out particularly the NHS commissioning cycle. Like in my experience of trying to influence policy and practice is that if you're able to produce some evidence at the right time, it can be really impactful. If it's not timely, then it can just sit on the shelf. And so trying to, at the minute, we're just trying to map out the kind of annual commissioning cycle of the NHS and thinking through actually, when the operating guidance for the NHS is being developed and when ICBs are being asked to submit their annual plans to NHS England, actually what are the key pinpoints, and then trying to disseminate the evidence at that point. And I think actually for all of us as researchers trying to understand the timely policy windows is really important.
Yeah, I think there's something magic there in how quickly you can turn around things, but then that part that you mentioned that has to happen before to identify the right questions, but also the part of disseminating afterwards might not always track with policy and practice timelines. That's the tricky part, isn't it?
Yes, yeah, and it's just difficult. We had an example of being asked by the 10-year plan team to pull an evidence back together, which we just dropped everything and did something over about 10 days. Yes, it's very difficult to know. We haven't heard anything back from that. It's very difficult to know whether it's simply a tick box for policymakers or to what extent it's worth dropping everything and busting a gut to deliver policymakers some evidence, because sometimes it sits on the shelf, sometimes it hopefully has some impact.
Well, we're approaching 11 o'clock, and so far you've answered all questions that have come up in the Q&A, so thank you very much for that. Thank you, John, for the day. If there's more questions coming up, please do put them in. John and I are happy to stay back for a minute if there's more questions. But just wanted to say thank you, everyone, for joining. I do hope it was a helpful session for you. I'm going to put a link in for a short feedback form. We'd love to hear from you. If you can take the time, we'll be happy to share the slides that John used. And also, just to announce, we've got a new webinar coming up on the 5th of March with Dr. Fian Curtis and Dr. Michelle Maiden, where we'll talk a bit more about how to implement an equity lens when conducting evidence synthesis that may be of interest as well. We'll circulate more information in the flyers, but just giving you the heads up. And thank you very, very much.